Hi, it's Dr. Centeno, and thanks for joining me today. We're going to be talking about what CCI patients should do if they also have a lower neck disc bulge. And it's a pretty frequent dilemma that I see. A lot of the CCI patients that I take care of have a lower neck disc bulge. And as a result, they're often offered surgery on this lower neck disc bulge. Now, I also see patients who have already had surgery on a lower neck disc bulge. And because their symptoms really had nothing to do with the lower neck, they are no better and now a little bit worse. So we're going to talk about all that today. As usual, you can ask questions about that topic. You can ask questions about any topic. The goal is to make sure everyone gets their questions answered. I'm doing this once a week now on Fridays, now that I'm back. So just let you know that that's the new schedule, Fridays at 1 o'clock Mountain. So let's see here. Going to start, actually, let me share my screen here and we'll get started. Okay, and again, the topic today is, should I get a lower neck fusion if I have CCI? So let's start talking about that topic. As usual, I'll focus here for about 5-10 minutes, then we'll open the floor up to questions. So should you get a lower neck fusion if you have craniocervical instability or CCI? So I see patients in this dilemma quite a bit. They have CCI with upper cervical symptoms. They have a neck MRI that has a disc bulge in the lower cervical spine, and the surgeons want to fuse that lower neck disc, or they want to give them an artificial disc replacement at that level. Now, I also see the other side of this, right? Patients who have already had the lower neck fused, they had upper cervical symptoms. Obviously, their symptoms weren't coming from their lower neck, and they're not any better. If anything, they're a little worse. So the big problem with fusing the lower neck is it puts more pressure on an already unstable upper cervical spine. Same thing with an artificial disc. Well, artificial discs are billed, i.e. marketed, with the idea that they are motion preserving. The research is really quite clear. They act just like a fusion, meaning you still get the same rates of adjacent segment disease as you would in a fusion. So either one of those, whether it's a fusion or an artificial disc, will overload the upper neck. Obviously, if you're already unstable in the upper neck, then getting more forces up there isn't going to be a net positive. So what should CCI patients do when they're in this dilemma? And again, I've seen a lot of patients in this dilemma. So one of the big things that surgeons use to sell surgery is, if you have a slip and fall or you get into a car accident, you're going to become paralyzed. Now, about 5 years ago, somewhere in there, I actually looked at this and found a really nicely done paper that showed that you were much more likely to become paralyzed by the surgery than you ever were from a slip and fall or getting into a car crash with a disc bulge or central canal stenosis. So at the end of the day, while this is a very powerful sales pitch, right? You should get the surgery, because if you don't, you might become paralyzed. The reality is, again, the surgery is much more likely to paralyze you than any of those events. So the answer is ignore this part of the sales pitch because it's not science-based. And I've talked before about this difference between upper and mid to lower cervical symptoms. And it's critical that you understand this, right? If you've got things like what's off to the left here, dizziness, vertigo, burning, tingling in the head, headache, upper neck pain, probably that has nothing to do with your lower neck disc bulge. Lower neck related issues are things more like shoulder pain, numbness and tingling in the arms and hands, upper back pain, upper trap pain. If the disc bulge is severe enough, it might even cause lower back pain. So just realize that if your main symptoms are headache, dizziness, vertigo, then getting your C5-6 or lower neck disc fused is very unlikely to move the needle. Now, the problem comes in when we have patients where they're sort of a mixture, right? They've got all the upper cervical symptoms to the left. They've got some of the lower cervical symptoms to the right. And that's where it gets hard. But I still see a lot of patients with primarily upper cervical symptoms who are getting their lower neck operated, and it should be a no-go from the start. So when there's a question, and so if you're in that middle, treat the CCI first, and then also treat the lower neck conservatively. The most conservative thing we do for that, which usually works pretty well, is we'll inject platelet lysate into those lower neck facet joints that leaks epidural or around the nerve. And the growth factors seem to help the nerve. And many times this gets rid of those lower neck symptoms, and it kind of takes this out from being an issue that we need to deal with. Now, if that doesn't work, the lower neck itself can be injected with PRP or bone marrow. So that's another possibility. That's a bit higher risk than what we just talked about, but lower risk than surgery. And if that doesn't work, then a discectomy would be far better than a fusion or an artificial disc, because in that case, there's no overload of the adjacent levels or segments, and that gets rid of the pressure on the spinal cord and nerve roots. So again, a discectomy. Now here's the hard part. The hard part is finding a surgeon that'll still do a laminectomy discectomy, because most of the surgeons have figured out that if they do artificial disc or if they do a fusion, the per unit time payment goes way up. So it's hard to find in some communities surgeons who are willing still to do a simple discectomy, taking off the piece of the disc that's putting pressure on the spinal cord or nerve roots. In summary, a lower neck fusion can make CCI symptoms worse. Getting the lower neck treated conservatively is always the first choice. Getting the CCI treated first is also a good strategy. Obviously, you want to stabilize up high first. And if surgery in the lower neck does need to be done, avoid a fusion or an artificial disc and try to find a surgeon that will do just a simple discectomy. So let me go ahead and go to questions here. And I'll stop sharing for now. Caleb, does prolotherapy produce new tissue that has scar tissue-like properties? Is this why it may benefit patients that have connective tissue disorders like EDS? No, the electron micrograph studies of prolotherapy seem to show that it just produces thicker collagen. Now realize that all scar means is that you have collagen laid down in a non-organized fashion. But for the vast majority of us, when we load that ligament, let's say, then the collagen gets aligned and becomes just a thicker ligament. Caleb, can PRP regenerate an old but minor ligament tear, or do you need to use BMC? If it's high dose enough PRP, I obviously need to know more, but in general, lesser ligament tears can be healed with PRP based on my experience. Rishi, I have a fixed retainer behind the top 6 of my bottom and lower teeth, thin wire. Is this an issue for PICL? Probably not. Rishi, how long does it take to see the results of an occipital nerve hydrosection when using platelet lysate? Pretty quick, within the first few weeks. Rishi, does the neck have a poor blood supply? And 3 smaller ligaments in the neck are whitish, yellowish color. It depends on the ligament. Damaged ligaments often, where regardless of where they are, often have a poor, because the blood supply can get damaged when the ligament gets damaged. Rishi, is it essential that you need a cervical MRI, not creating cervical MRI, in order to proceed treating lower cervical spine, posterior with PRP or stem cells? Same question goes for treating lower back and SI joint instability. The aim of this question is to know if it's essential to proceed without treating these additional areas without imaging. A lot of that just depends on the physical exam and the clinical scenario. We want to see cervical MRIs in general, meaning we want to see cervical MRIs in our patients just to make sure we're not missing something catastrophic that no one would want to miss. So my recommendation is always get an MRI in the area before treating it. Sometimes it can provide valuable information about how you're going to treat. Other times it's just making sure that you as the doctor aren't missing something big that no one would want to miss, like a tumor, etc. So we do like to get MRIs. John, do tendons and ligaments need different PRP concentrations? Tendons heal better because they're part of the muscle. No, pretty much the same PRP concentrations for both, and those are really determined by patient age. Rishi, what would happen if you poked a needle into the vertebral artery and injected contrast? Probably not much in a young patient. In a very old patient, someone in their 70s or 80s, you could have a mini stroke that gets caused by the calcified inner wall of the artery breaking off. But in a younger person, not too much. And now the bigger problem would be injecting something else into the vertebral artery. So if you were to inject something like PRP that could clot, that could cause a stroke. If you injected something like bone marrow that could clot, that could cause a stroke. Rishi, are there any ligaments or structures in the neck that PICL can't reach if damaged? Well, realize PICL is focused on the ligaments that are internal that can be reached from the front. Obviously, there are ligaments here in the back that you can't get to. That's why you do the back injections. So pretty broad question, but I would say, just to answer the concept of the question, that we can pretty much reach everything we need to in CCI patients through a PICL approach. Karen, we need you in India. Yeah, Karan, no intention to go to India, but I certainly hear you for sure. Rishi, what's the difference between Botox injection versus platelet lysate to treat occipital neuralgia? Completely different mechanisms. The concept behind Botox would be that we're going to make the muscles weaker. And because the muscles are weaker, the nerves aren't going to spasm as much, and the nerves aren't going to be irritated. The problem with that in a CCI patient is that they need all the muscle tightness they can get. So many CCI patients will get much worse with Botox because they need that muscle strength to try to keep things stable, and Botox reduces the muscle strength. Platelet lysate has growth factors in it, nerve growth factor, TGF beta, vascular endothelial growth factor, etc. And the goal is to make the nerve healthier. It's been advanced by Harry Winston. Great to see you back. I would hear as lower neck fusion recommended for me just last month. Yeah, Harry, it's a super common thing, and we see it in a lot of our patients, and a lot of our patients get very, very confused by that dilemma. So happy to help. Rishi, does orthobiologics work by inducing inflammatory response and directly delivering the PRP stem cells damage spot the body's own stem cells wouldn't otherwise get to on their own? There's an inflammatory response component, but realize, so let's just take something like platelet-rich plasma. Platelet-rich plasma has growth factors that stimulate repair. So it's a little bit like on a construction crew, if we got quad latte or quad espresso shots for all the workers, and we kept feeding them these quad espresso shots, they would work much, much harder. and they'd get more done that day. So that's kind of how platelet growth factors work, for example. Stable on 3. Once injected ligaments are healed, does the likelihood of re-injury increase or decrease at all, like bones healing stronger after a break? I don't think we know that one. Best I could say there would be in ligaments that we can see very, very easily, like the knee ACL, that are injected with bone marrow to try to get those healed. The re-tear rate is very similar to surgery, where the ligament is completely replaced. So we do see re-tears, but the re-tear rate is as good as if you went in and put a new tendon/ligament in there. Christy, thank you, Dr. Centeno, for your pioneering work in education regarding CCI. I'm curious about a case where you have significant instability at C0, C1, anterior posterior, and 1, 2, lateral and anterior posterior, along with moderate instability at 2, 3. How do you decide where to start? Does it make more sense to focus on treating enlarged transverse and the anterior and lateral instability first before focusing on the posterior instability? If so, why? I think it makes the most sense, Christy, just to treat it all at the same time. That's what we would do. So we would do a PICL to get all the ligaments that control lateral stability and any of the ligaments that are involved in anterior instability. And then we would do, posterior instability. Then we would do the posterior side at the same time in order to get any of the ligaments that control anterior instability. So it makes the most sense to do them all at once. Jim, how many of your CCI patients have significant weakening of the upper cervical muscles that need rehabilitation? A lot. I would say the vast majority of them have significant weakening that we can see on MRI that need rehabilitation. Daniel, is C1, C2 injections under local anesthesia safe? I think a lot of that depends on the patient. If the patient is rock solid and isn't going to move, then you can safely do it under local anesthesia. If you've got a patient who's going to shift their head or move when you get close to the, and sometimes that one can be a little painful if the patient's awake, then it's a no-go. Christy, I'm also wondering when someone can start trigger point injection therapy post-PICL in the neck, if they've had success with that prior to PICL. Shouldn't be an issue. I wouldn't want trigger point injections to happen as much as trigger point dry needling, which is really the same efficacy, because if we're injecting lidocaine, that can impact things. Lidocaine can be cell toxic. So it'd be better to do dry needling, but that can happen pretty much right away. Christy, last question. Do you inject the PAOM, PAAM, and PLL? Is there any evidence of damage to help with the posterior instability? Yeah, all of those can be injected. It's been advanced by Sherry Kopp. Welcome back. It's just lower cervical neck fusions that should be avoided with CCI, or would a low back fusion also be a problem? Less of a problem with regard to CCI, but can still potentially be a problem in and of itself. Caleb, for rectus capitis, major, minor, obliquus capitis, superior, inferior, tendonitis, how many PRP treatments does it take? Should be 1 or 2, but again, not a usual diagnosis, meaning those muscles don't develop tendonitis without some reason. So the question would be, what's being done to treat the cause of that tendonitis? And oftentimes that would be instability. Jing. Hello, Dr. Centeno. If the upper cervical spine is unstable, will it cause 24-hour dizziness? It can, for sure. The C2-3 joint in particular can cause dizziness. Todd Burke, discectomy seems like the most useful approach. I think so, yeah, in this particular clinical scenario. Bo Johnson, if a patient is considered to have central sensitization, is there anything that can be done to help before a PICL? Also, does that change the treatment plan? Yeah, the biggest change to the treatment plan is going to be that we're going to do less and start slower. Many times Lyrica as a nerve pain drug can help. Submitted dance by Jessica Jones. Unfortunately, I've already had a lower neck fusion. In my opinion, that's what caused my CCI. Would that disqualify me from getting the PICL procedure? Where a lower neck fusion wouldn't cause CCI, but it certainly might make it worse if it was already there. Doesn't disqualify you from getting the PICL procedure, but it is an important thing to understand that there's no way to undo the excess forces on the upper neck. Sabina, do you always inject all sacral ligaments on both sides and pubis symphysis in case of instability, or what you inject depends on how the pelvis is rotated and what the x-ray shows? Yeah, this really depends, Sabina, on the patient, but in general, we almost always inject the bilateral SI joint ligaments if there's pelvic ring instability. If the symphysis pubis up front, and that's the front part of the pelvic ring, is tender, we'll also inject there, or in a lot of women will inject there because they've got such a large force there because they've got wider hips. John, in about 20 years, what advancement of treatments of musculoskeletal problems in EDS do you see? Oh, I think we could see gene therapy, which would be fantastic. Bridget, I had a whiplash accident 30 years ago, C5-6 fusion in 2018 to remove bone spurs and fuse the slip disc. After surgery, I have severe pain in temples, my whole body feels twisted. With PICL help? I don't know, Bridget. We would need to do an evaluation to try to get a sense of whether or not you have issues with upper cervical instability. Todd, can PRP work for a detached ligament? Depends on what you mean by detached. And it's kind of not clear many times based on MRI reports. So it really necessitates us to look at the imaging, meaning that oftentimes we'll see MRI reports that say complete ligament tear, but there's still quite a bit of the ligament left. So in that case, PRP or bone marrow works well. If it's a complete retracted tear, which is often not differentiated on the MRI report, then injection-based therapies are not going to help. Manuela, what specific injection should we try for a stubborn C2 rotation? The first thing to do would be to see if that's related to either C1, C2 instability, and that would be more alar ligament. In that case, it would be treating alar ligament with something like a PICL procedure. If it's related to scoliosis and fixed rotation, meaning a side bending in the spine causes rotation, especially at C1, C2, then the scoliosis part would have to be addressed. John, have you considered using PRP for PICL in the second treatment if the patient doesn't respond to BMC? John, we haven't, just because PRP is less efficient at healing ligaments than BMC based on the research we've done. John, is high concentration PRP worse for young patients, or is just theory from a study you did that showed lowering stem cells in high concentrations in these young people? It's probably not worse, John. So I think what you're talking about is a tenocyte study we did in young people where you saw their tendon cells become a little less proliferative as you went higher on the dose. That can also be a function of other things as well. So it's probably not deleterious as much as it's just not helpful. Andy, would you say treating C1-C2 overhang with C1-C2 capsule injections is as stupid as trying to treat ACL injury but not actually injecting the ACL? Yeah, that's a good way to put it. It would be like saying I have an ACL injury. That's a main internal stabilizer of the knee. And then instead of injecting the ACL, you inject just the capsule or ligaments around the knee. You're not going to get a lot of stability for that person. You might get some people where you get them enough, maybe 1 in 5, where they say, yeah, I'm pretty good, I can deal with this. But for the most part, 80% of the patients are going to come back saying it's not really working because you're not injecting the right ligament. So listen, as I've said here before, I think the whole C1, C2 capsular thing is much more marketing than it is any kind of clinical reality, meaning that, and I think you've gave an apt example that you can't treat an ACL injury without injecting the ACL. You can't do it with just injecting the capsular ligaments around the knee. Russian, if an individual gets their stem cells expanded at the Cayman Islands, how many treatments can they get with one extraction of their cells? Many more than you could get just using bone marrow concentrate. I can only tell you sort of on the average patient. A lot of this depends on age, health status, etc. But the average patient in the Cayman Islands would probably have enough cells to treat at least 5 or 6 areas at once, sometimes more, and sometimes all of those and a lot of extra cells left over. Jennifer, I saw you in August for a PRP in my upper cervical. Just want to let you know that I've started to feel a lot better over the last couple of weeks. Oh, great to hear, Jennifer. Thank you for the update. Andy, have you treated tears in the PAOM? Is it just lax? Would one PRP be enough? We have treated PAOM, and we could use either PRP or bone marrow. It's a difficult ligament to hit because it's relatively deep, and the next deepest structure is the covering of the brain and spinal cord called the dura. So it's one you've got to do under x-ray guidance with contrast and be very careful to stay in that ligament and not get into other areas. Russian, I did not have much success treating my low back pain with intradiscal PRP. Would BMC be more effective? And I have an L5S1 disc tear. Yeah, Russian, I need to know more about what it is you did, who did it, what type of PRP was used, what concentration of PRP was used. Did they inject other structures like the facet joints, the ligaments, the muscles, et cetera, et cetera? Caleb, can atrophy of the suboccipital muscles cause their respective tendons to become inflamed, damaged? Maybe those tendons start overworking, which would warrant a PRP treatment. It's certainly possible, yes, but the real solution for that obviously is to try to get the muscles back. But listen, when we come out of the upper cervical facet joints, we are injecting into the suboccipital muscles and tendons as we come out. So those are routinely getting treated if we're doing upper cervical facets. Manual, I've had 3 PICLs, but C2 is still not staying in the right place. It's very rotated. I'm still trying to plan an approach to C2 moving forward. Yeah, Manuela, then the next thing you would want to look at is whether or not there's scoliosis, because scoliosis can put a fixed rotational force at C1, C2. So that would be the next thing to investigate there. Okay, guys, so we're at 30 minutes in. Any other questions I can answer from anyone out there? This would be the time. In the meantime, this particular talk is about this concept of lower neck disc bulges that might require effusion versus upper neck symptoms. First, trying to understand what comes from the upper neck versus lower neck, and then whether or not the lower neck needs to be fused, because we've seen a lot of patients either get it fused or told they need it fused when they don't really have any lower neck symptoms. So a very important concept. James, Dr. Southern here in Connecticut said he can do posterior injection of CCI from C0 down. Can I get treated here? Connecticut doesn't need a referral from Colorado. Yeah, the only place we offer upper cervical treatment in the network is in Colorado. There's no other place that we authorize any upper cervical treatment. So it's all Colorado only. Okay, guys. Great to be here. I'm going down to Grand Cayman this next week. So my schedule is different down there. I won't be able to do Facebook Live on this coming Friday. So that'll put us till the following Friday before I do a Facebook Live. Again, I'm on this now once a week, Friday at 1 p.m. Mountain Time, 3 p.m. Eastern, 12 noon Pacific. I'm going to try to hit every Friday that I'm here in town. After this trip down to Grand Cayman to see patients down there, I will be back in town through the holidays, so we should get 4 or 5 of these or more in before I go out of town again or have a conference or something like that. So appreciate everyone's time today, and you have a great weekend. And again, I won't be available for a Facebook Live this coming Friday, but I will the Fridays after that. So let's see, we got a couple more questions here. Submit advance by Harry Winston. Can I go cell treatment my posterior neck pre-CCI to see if that helps? That's something to definitely talk to them about for sure. Let's see what happened if you have severe arthritis in the neck. Like any other arthritis, it's got to be managed somehow. And the way that we usually manage that is doing high-dose PRP injections into those joints. Okay, guys, everyone have a great weekend. Thank you as well, Jing Jing, for the question. And I will be back not this Friday, but the Friday after that. Thank you.